I'm Dr. Stephen Feldman. I'm a periodontist in Venice, Florida, and I'm the CEO of Accept Communication Technologies, LLC. I would like to discuss with you a small PowerPoint presentation regarding really the definition of dentistry. In the past, in the distant past, when a patient had caries or when they had periodontal disease, their teeth were taken out. They were extracted. And initially, the endodontics came along and they saved teeth. And when they realized they could save teeth, and I think they experienced that to be miraculous in those days, then the periodontist said, well, if you can save teeth, then we can save teeth. So the periodontist began to literally save teeth by doing all forms of periodontal surgery in order to retain the teeth. And at that time, certainly the teeth, to do anything to help them to stay in the mouth, was in the old days of dentistry a miracle. And then care evolved and evolved, and materials got better and better, but we still were saving teeth. I believe the reality was we never saved teeth. We never fixed teeth. We had two choices. We either repaired them or we replaced them. And I think that's where we are now. We either repair or replace, and we have to discuss with the patients whether it's rational to continue to repair or not. For instance, in periodontics, you cannot continue to cut down the alveolus as if you were wearing a denture, watching the alveolus melt away from pressure. They're both not really necessarily the object of the exercise, because the alveolus, if you take too much away, then you have to advance bone grafting to get it back in order to get function back there vis-a-vis the replacement, the implant. So we may need to start rethinking exactly when we remove teeth or when we replace them as opposed to repair them. In medicine, especially in orthopedics, it's fairly simple. If you have a bad knee from tennis and you get it repaired, then that's one. And if it comes back again in 5 years and you have it repaired, that's two. And the third time you have a choice. You can either go in a wheelchair or you can have it replaced. That's their rules, and that's how they do it. And I think it's because you wouldn't want to continue to repair and repair and repair until your one leg was much, much shorter than the other, would you? So it's maybe the same thing in the mouth. Maybe we can't continue to cut away the bone in periodontics, for instance, which I am, or continue to watch and monitor these conditions erode more and more of the alveolus. So we have to be very careful. And my opinion is at this point that CBCT is really the testing apparatus, if you will, to determine what's the most rational, best form of risk assessment, their best odds of either repairing or replacing. So what I'd like to show you here on these PowerPoints is this. In the past, we've been treating with what we call symptomatic care, where something hurts or they have their denture is loose or a bridge has been loosened up, and that's what they do. The pain that occurs is rare and unusual in dentistry, and maybe it's just uncomfortable or somewhat different, but there's not too many early warning signs in dentistry, which puts us in what we call an asymptomatic subclinical zone, and not really a symptomatic zone like the knee or the spine, the shoulder, or the hip. So there's much difference. But we are an orthopedic model, but we're similar to an orthopedic model because we have hard tissue and ligament and hard tissue. In our case, it's tooth. In their case, it's another piece of bone, but it's still hard tissue, ligament, hard tissue. And in mammalians, that's genetically a must. You can't have bone on bone or bone on tooth. It's just not possible. So when the ligament becomes damaged, the bone migrates or it goes away. That's what it's supposed to do. So the notion that bone loss is the answer, it's probably more like ligament damage is probably the answer. So things are, I believe, changing for the better, and they're more rational, and the patients seem to understand it because it makes sense, If it makes sense in their hip, and if it makes sense in their knee, then it probably makes sense in their mouth. But to their confusion, why isn't it hurting me? I mean, why are you telling me to do something, as the patient would say, and it doesn't hurt me? Well, you're in an asymptomatic subclinical zone, and why is that? What's the difference between the neurology of the teeth, which is basically the opposite of the knee or the hip, and anything else? Why would a mouth look like this, and what would this mouth say? It's asymptomatic and subclinical. This person is at the state fair eating corn dogs and not having any pain. So why is that? That all this hard tissue is being eroded and they don't feel anything. I mean, that doesn't seem to be possible. It's certainly not possible in the knee, the hip, the shoulder, and the spine, that's for sure. So it's because we have to eat food and drink water. That's the survival area. So it's mandated in our body, in our lungs, in our hearts, in our mouth, in our liver, in our pancreas, and our bowel, and so on and so forth, that it's not going to hurt until it's too late, because you have to do those things or you'll die. It's essential. Those areas have to remain open and clear, and that's the way it is. So we can repair these areas, but that's what the mouth would say. It would say, I'm not telling you anything until it's too late. Now, on the asymptomatic side, these subclinical organs, you have to pump blood, you have to eat food and drink water, and we never think about it that way. We always think about maybe the mouth is a smile, or maybe the mouth is to talk with, or something like that, but actually it's to eat food and drink water, and that's how teleologically the species survived. Now, the interesting part from my standpoint is these patients, if it is subclinical and asymptomatic, which I think we know it is, then what are they like? And when you go to a cardiologist, or we go to a pulmonologist, or whatever the issue may be, it's tensing. And the reason it's tensing is because these areas are attached to the adrenaline pump. And the adrenaline pump, when adrenaline is surging through your body to any degree at all, it doesn't feel good. It feels like fight or flight. There's maybe a little pit in your stomach. Maybe you're just feeling very, very anxious and wondering what's next. So that's how people come into the dentist, whether they like it or not, whether they're very capable in every other aspect of life, where they're cognitive in this particular instance, they're not really aware that the adrenaline is surging through it. They just say, I hate to go to the dentist, I don't like going to the dentist. Or they look up at the periodontist or the dentist, like myself, and they say, don't you know that you're hurting me when I'm probing them? And these are people that have, maybe had gunshot wounds and can endure that much easier than even going to the dentist. And they often say that to us. So it's from the adrenaline pump. It's really not their fault, and it's not their intention. But we need to know that because we need to know who we're dealing with. So what we're seeing with having a CBCT in our office now and using that as a primary diagnostic tool, not that we're not probing, but we're doing a lot of the diagnostics before we do that, is because we're able to do it that way, and it's much more peaceful for them. They get a much better idea as to what is going on in their mouths. So the question is, if you have to eat food and drink water, why get a CBCT? Well, obviously because you need the data. The question really is if it doesn't hurt, why would you take a pan, for instance, or a periapical when you know the data would have to be in 3D in order to really get it? So don't waste the radiation on something that's not going to give you enough data. If you're going to irradiate patients, certainly take a CT. It makes sense. It really does. As dentistry is moving forward into this orthopedic, asymptomatic subclinical model, it makes sense to have a CT in your office. It really does. Now, what does it mean it doesn't hurt? What does it mean asymptomatic subclinical? Well, let's just talk about going out for pizza. I think everybody listening to this likes pizza. I doubt if we don't. You go out, you get hot pizza, it burns your palate. Okay, it's a second-degree burn. Your palate's bubbling a little bit. You're hungry. You have another piece, don't you? If you put your finger in the cheese, you won't pick up the piece. All right, so it's very different. The neurology is very different in these areas. So that's why when patients have dentures and the denture is sitting on the ridge, and because there is no ligament there, that means the ridge is not a shock absorber. You might as well be putting bricks underneath your denture. It's going to erode away the denture up and back, and the movement in the face is going to be moving up and back. And from that standpoint, the patients don't know this, and that's asymptomatic and subclinical. Now, why would anybody have their face erode up and back and not know it? If your leg was getting shorter, I promise you'd feel it. It wouldn't just get shorter. So this is what happens to us in dentistry, and it's my belief that patients need to know that this type of occurrence really happens, what you're seeing here, where someone starts off normal and they end up abnormal because they're really not aware of it. It's slowly, over time, almost like a flower opening. I'm Stephen Feldman. I'm a periodontist in Venice, Florida. I've been practicing periodontics for over 30 years, and I've placed over 14,000 implants. And this right now is the most exciting time in my dental career. And it's not because I'm the CEO of Accept Communication LLC, which is exciting, but it's because of the diagnostics that I'm doing now, that I'm able to do now that I've never been able to before. I've been using CT and CT software for over 5 years now, and very successfully. But to date, I've been sending out the scans and having them come back in. And recently, we acquired a CT from Kodak, a 9500, because I'm a software guy. I picked that because of the software that's in there, because it allows me to navigate or glide through their mouth and diagnose every little bit, both periodontally, endodontically, and whether to repair or replace a tooth meaning should we fix the tooth, as you would say, or save the tooth, as you would say, which I don't. I say repair it, or should we replace it? So it tells me where I can place implants, or where I need to, or where I don't need to, or where the teeth can remain, or where they can't. So I like that the CT for that. But now that it's in my office, almost all our patients are getting, or many of our patients, and a lot of patients are getting CT, because when they have a question that I can't answer, I have some choices. I can tell them that this is a very educated guess, and in my experience, I think this is what it is. Now, if my cardiologist listened to my heart and tapped on my back and looked at my cholesterol test, and that's all, and then said to me, Stephen, here's what I think, I would probably say to him, is there any other tests you could take to be sure? That's what I would say. So the CT allows me to look at a patient and say, I think it's this way, but why don't we take the CT? The reason I use the CT is because I can give them a clean bill of health where they're normal, and if they're clinically normal at that point in time, and they're such and such an age, we can probably predict how normal they'll be long term. But they like having a clean bill of health. I mean, if you think about it, when was the last time you took a test in medicine for $200 or $300 or $400 and it told you were perfectly healthy? I think all of us would be very happy to pay that fee, and all of us would be very healthy. And all of us would tell everybody that we're so healthy. So a clean bill of health is a wonderful thing. So in my office, we find out where the challenges are, or where we think future needs will be, or present needs are, and we also tell them where their teeth are clinically normal and maybe even look like they're 16. So my patients are happy to have that. They want to know the data. They want to know they're okay, because dentistry is asymptomatic and subclinical, and because these people are coming in adrenalized, they literally have some amount of adrenaline surging through them because they're going into an office that's about asymptomatic and subclinical, meaning they're never going to know until it's too late, meaning they don't feel anything. And if they don't feel anything, they're nervous to find out maybe what they'll find out that they don't know. And that is, those areas, like the heart and the lung and the liver and all the other areas, are attached to the adrenaline pump and the mouth, because you have to pump blood, you have to breathe, you have to eat food and drink water. You have to. So these areas are attached to the adrenaline pump, and for that reason, the patients are nervous, and the nervousness comes from the adrenaline. It doesn't come from the fact that they're nervous, because these people may be jumping out of airplanes just for fun, okay? But they're nervous coming into the dental office, and we hear that time and time again. So be aware of the adrenaline pump. What we're finding with CT and our software, the Accept software, is that it calms them down, because reality, their cognitive thinking stops the adrenaline pump. They start looking at what they have, and they're realizing that most areas they're okay. It's not as bad as they thought, or it's real, and whatever is real is better than what's in their mind vis-a-vis adrenaline. So here's what I have. And this document that you're looking at, showing the implants replacing, these are pieces. Every one of these are little pieces. That's a crown with an abutment in it. All the teeth are numbered before they come in. This is a portion of the CT that we captured. This case was originally like this, so just focus here on the periapicals. This patient came to me, her periodontist, with a periodontal condition. The dentist recommended down here on the lower left-hand side that we place CT grafts, because it was very fragile. She had a little bit of lichen planus. I probed around her all over. Probing was not that significant, a little bit here and there, but nothing, in my opinion, major, and the grafts were the most important part of it. Here's what really happened. I misdiagnosed it. I opened up the CT, and it's set up by my staff. They take the CT, they orient the markers, and I'm going to, these implants were planned. I'm going to remove them for a moment and kind of show you what happened to us. So here's where we were. If you see this blue line, I show them the blue line. I start scrolling. I show them, here's the bone. This is the dense bone. They can see the density units on the lower right-hand corner, the 1271, if you can see that. And I just kind of tell them that I'm looking for what's normal in their mouth, because what's normal in their mouth may look abnormal in another mouth. Now, and I start rolling this scroller, scrolling, and all of a sudden they'll see the root of the tooth and the crown occur. And you see this dark spot here? This is a fractured root. Remember, this was misdiagnosed by me, yours truly. So it doesn't matter how many years you've been in periodontics. You don't have the right tools. What's the difference? So in my experience, I was CT grafting here, And if you can see what's going on here, look at the enormous pocket that's here. I missed it, and this is what I found on the CT. So I immediately took this picture. This is my data. I captured it with the Accept Capture tool, and I placed it into our software, like that. And there it is. So I've already done this, and here it is right here. And then we planned the implants, and I captured those as well. So this is what I call the evolution of care. So I'm showing an implant being placed here in number 18. I'm showing an implant being placed here in number 19, where she did not come in for that. And I'm also showing a few other things. I'll show you what I do. I'll go into the CT again. So when I see something like this, for instance, where we're going to be removing this tooth, then I immediately verify it by going into the 3D. And I'll take a look and see if I can see, and I can, and you can, and you can as well. You can see the amount of loss that's occurring around this tooth. You can literally see it. And if I want to, I can obviously do this and recapture this area as well. If I wanted to, and right-click on it and copy it, and then go back into our software again and document it by pasting it. And here it is, showing literally what that is. And if I care to, I can actually arrow it or do what I want with it and show it. So that's what I do. It's very simple. And I'm demonstrating two things. Number one is when I'm performing the surgery, I'm actually seeing what I was thinking at the last moment when I saw that patient, because after that, they leave and the next patient comes in and we schedule and do all the things that you do. So I need to know whenever I need to know, at least definitely before the surgery, but maybe some other time, if another time, if their restorative dentist calls me and has some questions about the case, about the temporization or whatnot, I need to know what I was thinking at that last moment in time, because they're going to want to know quickly, what do I think of this? You know, the question that we all get, or we ask that of ourselves. So this allows me to always know what I was thinking and what type of care and what was the diagnosis at the time. I don't have to go back to the CT, read all my notes, and go through that long process. So it's very quick and easy, and everybody's happy about that. Now, in this particular case, when I was in the CT, which I find absolutely invaluable, I placed the implants, let's put them back in, and I sliced through all the teeth to see the location of the implant, because it was important to get the implants exactly in the right alignment. And in order to get them in the right alignment by my standards and the restorative dentist standards, this needed to be placed out off the bone slightly. So I did that, and I captured this again with our capturing tool. So I captured this piece, I copied it, and I pasted it, and then I pasted it here over here. And we're going to be placing an infused extra small graft there, and we're going to batter it with Pyros, and then I'm going to place 3mm healing abutments on these implants, tent the skin up to stay away from the RHBMP2, the recombinant human bone morphogenic protein 2, the infused, and I'm going to do what I would traditionally do, a block graft or an onlay graft there. I'm going to do this onlay graft with infused. And while we're doing this, with the Kodak 1500 wireless intraoral camera, we're getting these beautiful pictures, and this is showing the placement, the extraction of the tooth in the back, number 18, placement of infuse around it. Here's the infuse. It's colorless. It's a sponge and very simple to place. Here's more of it being placed on this implant here, which was placed. You see where we decorticated the mandible here, so we get some bleeding areas because infuse requires bleeding. It needs a blood supply, and then we place a layer of infuse, and then on top of that, this is just re-showing you where these threads were. We place battered, I call it battered, it's taking the infused sponge, pieces of it, and dipping it in Pyros or Bioos or Mineros, something like that, and placing it over the first layer, and then continuing to, and then placing the 3mm healing cabinet, and I suture it so it's slinged or tented above, and that's what I do. And this is just showing. But this was done on the fly. There was Very simple to do. I didn't have to have an extra person in the room filming for me at all, as I have in the past. And it was just real easy. It really is. And these are just follow-up photos, and I think there are more. And we also placed a free gingival graft simultaneously. This is showing it going off the palate with a paquette, which I got from Selvin. And it's placed here to add some attached gingiva, and then later, during the uncovering of the implant, I'm going to pull this tissue up. So here's, this here showing the implant placed is my surgical letter. See, it says surgical letter on February 17th. This is when I did this case. It shows I placed Zimmer implants and I used Infuse, and here's the implants and the periapical radiograph that was taken the day of the surgery. And there was a custom letter about this case placed in here, and this was sent off, emailed to the restorative dentist, printed for us because we're still not paperless, showing the evolution of care again. It's all on here so the doctor can see it again, so he knows exactly why I did and what I did and what were the problems or what could have been the problems. And it shows the placement of the implant planned out in the DICOM. So, to make somewhat of a long story short, I'm very pleased to have the CT in my office. I think it's not an option. I think it's a necessity. I know all of you are afraid of, or some of you are afraid of, can you afford it or can your office support it financially? I want you to know that it's a very, in our office is a very strong profit center really, but not for that reason. It just turns out that way because instead of taking the PAN and having revenues from PANs, we have revenues from CT, but we have data from CT. So the patients are healthier as a result of it. The patients know where their care is going or needs to be going and where they need care. They really do more care as a result of it because it's real. It's absolutely real. And they go by what the science says, just like they do with their physicians. And whether we know it or not or like it or not, that's the direction we're going into. We're going into a much more data-oriented, scientifically oriented, if you will, dentistry. And I'm proud of it, and I think we all are. And I like the idea that we're moving more into orthopedics and further away from the past, which is our foundation, but further away from that into some very exciting times. So I thank you for taking the time to watch this and going on Dental XP, and I'll see you again.